Hello everyone. Today we'll be talking about 20 previous year questions from the topic of CNS from pediatrics. So first question is neonatal causes of seizures which carries the best prognosis, right? So your options are perinatal asphyxia, hypoglycemia, bacterial meningitis and late onset hypocalcemia. Now perinatal asphyxia, we all know that this can have sequelae, okay, sequelae in terms of seizure, seizure disorders, developmental delay. Hypoglycemia in the newborn period can cause mesial temporal sclerosis, right? Mesial temporal sclerosis, that is a known long-term complication of hypoglycemia in the newborn period, and temporal epilepsy. Bacterial meningitis, it can cause hearing loss, it can cause developmental delay, hydrocephalus, right? Hydrocephalus, post meningitic sequelae. Late onset hypocalcemia can cause seizures, and among all the other options does not have long term sequelae. So, late onset hypoglycemia carries the best prognosis among the options that are given here. All are features of absence seizures except. So, your options are usually seen in childhood, 3 Hz spike waves in ECG. Sorry, this has to be EEG. Postictal confusion and precipitation by hyperventilation. So in absence seizures, precipitation by hyperventilation, yes, this usually there is a trigger. There may be other triggers like flashlights or sudden excitement and bright lights, and hyperventilation can also trigger a absence seizure. This EEG finding, 3 Hz spike waves in EEG are very typical of absence seizures. These are seen in childhood, so this option is also correct. Postictal confusion, no. Absence seizures typically do not have postictal confusion like that you have in generalized seizures. So all the other features are true, but postictal confusion is not a feature of absence seizures. Decorticate posture, what is false among the following? Now here in this picture you can see decorticate and decerebrate. Okay, acute brain injury, yes. Decorticate posture can be due to subthalamic, internal capsule and frontal lobe lesions. More severe than decerebrate lesion? No, decerebrate lesion is more severe because it involves the brain stem, right? It involves the brain stem. Flexion of arms and extension of lower limbs, yes, as you can see in this picture, there's flexion of arms, extension of lower limbs. So decorticate posture, all the others are true except that more severe in than decerebrate lesion, that is false. True about Reye syndrome is all except. Now Reye syndrome, we all know that there is encephalopathy and hepatic failure following a viral illness and use of aspirin. So in Reye syndrome you see microvesicular fatty infiltration of liver. Yes, you see that in Reye syndrome. Deep jaundice, no, that is not a feature of Reye syndrome. You usually see elevated enzymes, elevated ammonia and elevated prothrombin time, right? And you see features of hepatic encephalopathy. Deep jaundice is not a feature of Reye syndrome. Cerebral edema, yes. Hepatic encephalopathy, yes. So all the other options are true except deep jaundice. And here you are seeing a histopathology picture of the liver cells with fat in it, okay, fatty microvesicular cytoplasmic inclusions in the hepatic cells. This is a picture of that. Which of the following is a preventable cause of mental retardation? Your options are hypothyroidism, Down syndrome, cerebral palsy, and all of the above. So Down syndrome and cerebral palsy, okay, for Down syndrome prenatal counseling is available, but it is not completely preventable. Cerebral palsy, no, you cannot prevent all the causes of cerebral palsy. Hypothyroidism, although you cannot prevent the main existential cause of hypothyroidism, but you can correct the deficiency of the hypothyroidism. You can correct the deficiency of the thyroid enzyme and prevent the mental retardation. So which of the following is preventable cause of mental retardation? The answer is hypothyroidism. A 2-year-old child without fever develops bone pain, vomiting, and features of raised intracranial tension following excessive medication. The drug most likely responsible for this is. So, first of all, what is this? This child is 2-year-old. This child has no fever but has bone pain, vomiting, and features of raised ICT following excessive medication. So, from this, we know that we are talking about pseudotumor cerebri in this clinical scenario, and the common medication excessive dose or hypervitaminosis A can cause pseudotumor cerebri. So the answer to this question is vitamin A. A neonate developed signs of meningitis at 7 days of birth. The presence of which of the following infectious agents in the maternal tract can be causative agent of the disease? Now here the options given are Neisseria gonorrhoeae, Chlamydia trachomatis, Streptococcus agalactiae and Haemophilus ducrei. Now what are the clues here? Developed on 7 days after birth, and the organism is in the maternal genital tract. So group B Streptococcus, GBS, group B Streptococcus, which is Streptococcus agalactiae, it is the most common cause of neonatal meningitis and sepsis also. So here the answer is Streptococcus agalactiae, which is group B Streptococcus basically, which is present in the maternal genital tract and can be transmitted at the time of delivery to the baby and present as meningitis or sepsis in the baby. Initial drug of choice in a child with status epilepticus. So what is the drug of choice? Status epilepticus, the child is actively having seizures, so you need a fast acting drug, short acting drug, and that will be a benzodiazepine, which is lorazepam. Phenobarbital, valproate and phenytoin will be the maintenance therapy for the seizures. Also that will depend on the etiology of seizures that we are suspecting clinically. But the initial drug of choice is lorazepam or another benzodiazepine basically. Most common complication of meningitis in children is, your options are hearing loss, seizures, hydrocephalus and visual loss. Now technically all of these can be complications of meningitis, but seizures are the most common and they occur in about 15 to 30% cases of meningitis. Okay, and why does that happen? Because the inflamed meninges are actually irritating the cortex, the cortical layer of the brain, and that can cause seizures. So the most common complication of meningitis is seizures. Most common sequelae due to periventricular leukomalacia. We all know this. The most common sequelae of PVL is spastic diplegia, spastic diplegic CP, and this is the most common CP in preterms who have periventricular leukomalacia. A 6-year-old boy has been complaining of headache, ignoring to see objects on the sides for 4 months. On examination, he has no intellectual disability. His scholastic performance is good. Visual acuity is reduced in both eyes. He has field defects on visual charting. CT scan of the head showed suprasellar mass with calcification. Right, so this is your clue in this question. Which of the following is the most probable diagnosis? His visual acuity is reduced, he's got field defects on visual charting, right, and he's got headache, and he is ignoring to see the objects on the sides for the past 4 months. So there is some developing brain lesion which is causing all this. Now astrocytoma, your options are astrocytoma, craniopharyngioma, pituitary adenoma and meningioma. Astrocytoma, it is usually infratentorial lesion. Here we are talking about a suprasellar mass, plus it does not cause all these other things which is visual acuity and field defects, right? So astrocytoma is out. Craniopharyngioma, the typical pathologic feature is calcification, suprasellar mass with calcification. Your instant answer in your head should be craniopharyngioma, but of course you have to rule out other options. Pituitary adenoma, they have not given anything related to any hormonal changes like that of hyperthyroidism, excessive steroid secretion in the body, or increased growth hormone causing other features like acromegaly and all. So none of that is given. None of the features of reduced hormones, that also is not given in this um, question. Pituitary adenoma, it's very unlikely. Plus pituitary gland is in the sella, okay, and when it extends vertically, then it can cause supracellular extension. As such, supracellular mass by itself, it's not pituitary adenoma directly. Okay, supracellular, if it is from pituitary, it's an extension of the pituitary mass into the supracellular region. Meningioma, again, it is unlikely in this case, because meningioma, the typical symptom is there may be weakness of one side of the body, there may be seizures, right? So meningioma is also not the answer. So supracellular mass with calcification along with visual field defects, craniopharyngioma is the answer, and we have ruled out the other options. Triad of seizures, intellectual disability and sebaceous adenoma is seen in, we all know this, this is seen in tuberous sclerosis, and this is a picture of sebaceous adenomas. Okay, so seizures, intellectual disability and sebaceous adenoma is seen in tuberous sclerosis. A 10-month-old child presents with 2 weeks history of fever, vomiting and altered sensorium. Cranial CT scan reveals basal exudates and hydrocephalus. Most likely diagnosis or most likely etiology is, now basal exudates, as you can see on this contrast enhanced CT, you can see basal exudates and hydrocephalus. Okay, basal exudates are very typical of tuberculous meningitis. Although you can see vomiting and fever in other forms of meningitis also, bacterial meningitis and all, like streptococcal, listeria meningitis, but basal exudates, if that is given in the question, instantly it should ring a bell that the answer could be Mycobacterium tuberculosis. Which viral meningoencephalitis causes low CSF glucose? Now low CSF glucose is a typical feature of bacterial and fungal meningitis. It is not a feature of viral meningoencephalitis, but mumps is an exception. Mumps meningoencephalitis causes low CSF glucose. This you will have to remember only. A neonate develops encephalitis without any skin lesions. Most probable causative organism is, your options are HSV1, HSV2, meningococcus and streptococcus. So a neonate that develops encephalitis, there are no skin lesions. Okay. Now meningococcus, usually the antibodies are passed on from the mother to the baby. So neonates, meningococcus is not a common organism to cause meningitis in a newborn. Streptococcus, no, because streptococcus typically causes meningitis. The question here mentions encephalitis. Streptococcus is out. HSV1 and 2 both can cause encephalitis, but here they are saying it's a neonate. HSV2, because it can be present in the genital area of the mother, HSV2 lesions, so that can cause encephalitis in the newborn without any skin lesions, right? We all know that HSV1 is usually the oral lesions and HSV2 is genital. So HSV2 is the right answer in this scenario. CSF examination of a patient shows high protein, markedly low sugar, low chloride and increased neutrophils. Okay, the diagnosis is, now increased neutrophils is a clue in this question, right? Increased neutrophils is usually seen in bacterial causes of meningitis, right? High protein and low sugar may be seen in other forms of meningitis also, right? But increased neutrophils is very typical of bacterial. Your options are meningococcal, tuberculous, cryptococcal and viral. Viral meningitis is out. Increased neutrophils, again fungal and tuberculous meningitis are out. Your most likely answer in this scenario is meningococcal meningitis. Drug of choice in absence seizures is ethosuximide. Okay, drug of choice is ethosuximide in absence seizures. Banana sign is seen in the fetus in, now this is an ultrasound sign. Here you can see that in the prenatal ultrasound there is an abnormally curved and banana shaped cerebellum. Like you can see, this is very clear in this picture actually. This is a banana shaped cerebellum with inferior displacement of the cerebellum around the brainstem, and there is obliteration of the cisterna magna. So this banana shaped thing here, banana cerebellum, this is seen in spina bifida, right? This is seen in spina bifida. The corticosteroid used in cerebral edema is dexamethasone, right? The corticosteroid used in cerebral edema is dexamethasone. And your last question is, a 25-year-old man with congenital heart disease complains of headache. On exam, there is a systolic murmur best heard on the left side of the sternum in the fourth intercostal space. Second heart sound is not split. He is afebrile, and what is the most likely diagnosis? Septicemia, cerebral abscess, cortical vein thrombosis, encephalitis. Now, encephalitis, there is no such clue in the question because his sensorium is normal, right? Cortical vein thrombosis, again, there is no seizures, no weakness. So, cortical vein thrombosis is also unlikely in this question. Here you are seeing the most important clue here is congenital heart disease. Okay, we all know that in tetralogy of Fallot, which is a congenital heart disease, there can be a paradoxical embolus, right? Paradoxical embolus, septic embolus that can go from the right to left side of the heart, and from the left side of the heart it can go to the brain and it can cause stroke or a brain abscess, right? So this congenital heart disease is the clue here in this question. Paradoxical embolus causing right to left shunting and causing a brain abscess. So cerebral abscess is the most likely answer here. Septicemia, again this is very non-specific. Septicemia, here the typical symptom they have given here is headache, and he is not febrile. Okay, brain abscess may not have fever all the time. In this particular clinical setting, cerebral abscess is the most likely answer. I hope these 20 questions have helped you. Stay tuned for more such videos.